All right, good evening, everybody. My name is Jeff Healey. I'm a cardiologist at Master University in Hamilton, Canada, and I'd like to welcome you to our program entitled Breaking News from the AHA 2020. And along with my co-host, Harriette and Spall, we have a really nice evening for you tonight, or whenever you choose to replay this, with 4 great trials and the trialists themselves to discuss things. I'd like to introduce Harriette, who's going to introduce herself now and get to meet the panel. Then we'll go on to describe what's in store for the evening. Thank you, Harriette.
I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist at McMaster University, and I'm delighted to be here and co-host this event with Jeff. And I'm pleased to allow Erin Mikos, my colleague from Hopkins, to introduce herself next. Erin?
Yes, hi. I'm the social media moderator tonight, and you can tweet all your questions for the trialists either to my own account or to the hashtag HACAN20, which I'll be following as well.
We'd like to present our disclosures before we begin this evening. Craig, can you advance the disclosure slides? We are delighted to bring you 4 impactful trials that were recently presented at the American Heart Association meeting. These trials tackle treatment approaches in 4 key areas in cardiovascular disease: cardiovascular prevention, chronic kidney disease, heart failure, and atrial fibrillation. So without any further delay, I'm going to turn this back to Jeff to introduce our first speaker.
Thank you, Harriette. And the first speaker, I'm really pleased to introduce Dr. Salim Yusuf. He is the director of the Population Health Research Institute in Hamilton, Ontario, Canada, recipient of the Order of Canada and of the ESC Gold Medal. Dr. Yusuf has really been one of the pivotal trialists in cardiovascular medicine over the last 30 years, and he is going to talk to us today about the TIPS3 program. Without any further ado, welcome, Salim. We look forward to hearing from your presentation.
All right, folks, it's late in the evening. Welcome to everybody across the country, whoever's attending. I would have thought you'd had better things to do on a Thursday evening at 7 p.m., but apparently not. I'm going to share with you the results of the polypill trial that we completed. Okay, there we are. Those are my disclosures. The majority of the study funding came from the Wellcome Trust, PHRI-chaired, and Heart and Stroke Foundation, and from governments in Philippines and in Colombia and in India. A small amount, about 10% of the funding, came from the pharmaceutical company Healey. The hypothesis around the polypill is that risk factors versus cardiovascular disease is a graded relationship. So if you change, if you modify the level of the risk factor from any threshold, any baseline level, you should get a proportionate decrease in events. The second thing is we know in secondary prevention, beta blockers, statins, ACE inhibitors, and aspirin each lower risk by about 1/4, and the 4 together probably by about 70 or 80%. And a year after I wrote that paper, or 2 years later, Walden Law said, well, we have to go beyond, and let's use a combination of 3 blood pressure lowering drugs at half doses, and that could reduce blood pressure by 18 millimeters, which should lead to a 40% relative risk reduction in stroke and MI. And a dose of, and statin should lower LDL by 1.8 millimole, so should lower risk by 40%, aspirin by 25% risk reduction. And they said homocysteine lowering with folate and B6 should also work, but we know that doesn't work. But they estimate that the combination of these 3 will lead to an 80% risk reduction. We didn't believe it could be that big, but we thought maybe it could be a 40 or 50% risk reduction, and we were interested in testing it. And so this is in primary prevention, not a secondary prevention. So we had 3 objectives. We wanted to see what the polypill versus placebo did in cardiovascular events, aspirin versus placebo on the same events, and the combination of polypill plus aspirin versus double placebo in primary prevention. As you know, the role of aspirin in primary prevention is controversial, so it was important to test it. We used a factorial design where we randomized people to the polypill or placebo. Then each of the two groups were further randomized to aspirin or placebo. So we would have a group with aspirin plus polypill, polypill alone, aspirin alone, and double placebo. And the polypill included a beta blocker, an ACE inhibitor, a thiazide, and simvastatin, and aspirin was at 75 milligrams a day. The eligibility criteria was such that we were targeting an event rate of over 1% per year, and we used age as a key cutoff and an elevated risk using a composite score. We excluded people with vascular disease. We ended up with 5,700 people. 5,000 was our minimum sample size, 7,000 was our optimal sample size. We ended up somewhere in between. We had huge problems with conducting the study. I've never done a study with so many problems. So it took 5 years to recruit instead of 2 years. And then with COVID, that also brought a halt to a number of things. The mean age was 64 years, about half were women. 83% either had a history or had an elevated blood pressure over 140. About 55-60% had hypertension, the rest were newly diagnosed elevations of blood pressure. Diabetes, known, or elevated glucose was about a third of the people. Smokers was very low, so it's largely a non-smoking population. Systolic blood pressure was about 144 in the study. Total cholesterol was about 200, with LDL being about 120, that's about 3 millimoles. And the mean heart risk score was really quite high. That's about 18. That suggests about a 1.5 to 1.8% per year event rate. So we definitely did achieve a high-risk primary prevention population. This is the impact on risk factors. We see early on, we had about a 10 millimeter difference in blood pressure. But over time, that difference attenuated. Part of this is due to non-adherence. As part of this, maybe just the body adapting. And throughout the study, the mean difference was only 6 millimeters. This was about a third lower than we anticipated based on our pilot study. Our biggest surprise is that the LDL effect was smaller. We only had about a 19 milligrams per deciliter or half a millimole difference, and we had expected something closer to 1 millimole. So to start off, we had a lower effect on risk factors, and we don't fully understand why. And this is the clinical outcomes. Despite that, we had a 21% risk reduction in events. That is not just borderline significant. Consistent results when you take the secondary, which is more narrow, CV, death, MR, stroke, or another secondary that was broader, that had angina. And if you look at recurrent events, there was a 24% risk reduction, and there was a trend towards lower mortality. Yes, there is apparent benefit, but really the benefit was smaller than we expected. And you will see that most of the individual outcomes that's reasonably frequent was less common in the polypill group. CV death was 18% lower, MI was 34% lower, stroke was about 29% lower, and revascularization, there was a huge effect, a 50% treatment effect with the mean follow-up of 5 years. Now, we had a lot of problems with adherence due to 2 reasons, the usual problems, but we had 2 very special things that happened in the protocol. First, because of delays in manufacturing the polypill, packaging, shipping it, and customs and regulatory delays, a number of shipments did not reach the sites well after several months after the study patient ran out of drugs. So patients stopped drugs for no medical reason, just for an administrative reason. And then because of COVID, again, even if drugs got there, we weren't able to resupply them. So we wrote into the protocol before unblinding that events that occurred after 30 days of an event, as long as that 30 days of stopping the drug, as long as the stopping is not for medical reasons. So if they stop for hypotension or dizziness, they continue to be counted. So you will see on the right side are the total number of events on an intention to treat analysis. The middle group is the events after 30 days, like a sensitivity analysis in those who stopped for non-medical reasons. And this here are the events in those who continued the drug. And it's a little more pronounced. It's a 26% risk reduction, which actually fits very well with the degree of risk factor change. When you look at aspirin, there is a 14% risk reduction, which is identical to what was seen in the meta-analysis of prior trials. And although, what's happened? Okay, and although it's not statistically significant, this is what you expect based on the primary prevention trials. And so this reinforces what we all know. What I didn't show because of time is we had no excess bleeding, either in the GI system or in other organs. And this may be because we had a 3-week run-in period with low-dose aspirin. And the second thing is we may have used the very low dose of aspirin may have actually led to less side effects. These are the data on the combination of polypill plus aspirin versus double placebo. The red is double placebo, the green is double active, and the blue is aspirin alone, the polypill is in between. And you will see each of the aspirin and polypill does have an effect, but the combination has nearly a 31% treatment effect, which is nominally significant. Now, these are the individual data points on individual components, 83 events in double placebo, 59 with combination, a 31% effect, nominally significant. If you focus on the harder endpoint, the same result. If you look at the broader endpoint, the same effect size. And if you look at recurrent events, the same effect size and about the same statistical significance. Interestingly, there was a tendency towards lower cancer with aspirin, which has been described before, although that isn't significant, but it requires probably longer follow-up. And total mortality was 20% lower, which, although not significant in primary prevention, is substantial. And you will look at the components of, the components of the primary endpoint, a 30% reduction in CV deaths, MI, and a 60% reduction in strokes. When you look at revascularization, about a 60% effect, angina, about a 40% effect. So when you look at the effect, now you'd say these are borderline significance, but this is identical to the results of another trial called the PHRI trial that was published a year back in the Lancet with the combination of polypill plus aspirin. So, a 30 to 40% treatment effect is likely, and this is the analysis after controlling for non-adherence due to administrative reason, similar number of events after stopping, and on treatment, there's a 39% treatment effect. So somewhere between a 30 and 40% treatment benefit you can get with polypill plus aspirin. This is a pretty cheap and inexpensive combination that will cost probably less than somewhere in the range of 25 cents to 50 cents a day. So in conclusion, in an intermediate primary prevention population, intermediate risk primary prevention population over 4.5 years, the polypill reduced risk by 21%, on aspirin by 14%, and the combination of polypill plus aspirin by 31%. That's an intention to treat analysis, and we had unexpectedly high non-adherence for the factors I said. And when you focus on a sensitivity analysis where you remove events that occur when people stop for non-medical reasons, and you'll see it was similar between the active and control group during that period, there's a 40% risk reduction with a polypill and aspirin. This is a far cry from the 80% risk reduction that Walden Law suggested. We had hoped to get 50%. This is closer to that. And honestly, this is still enormously worthwhile. It's possible that in future, with better polypills, which have probably better bioavailability and stability, we might get bigger blood pressure lowering effects and bigger LDL lowering effects, and that should lead to greater benefit. And a subgroup analysis in the study suggests that. So this was published about 4 weeks back in the New England Journal, and it was unusual because they gave us about 50% more space than the usual paper and 50% more tables and figures. So we're grateful to them for allowing us to do that. I'll stop here and take questions.
Thank you, Salim. That was excellent, and another tour de force with outstanding clinical trial. It never ceases to amaze me, the new challenges that one can encounter as trials are done. Just a reminder to people, Aaron's going to field questions via Twitter as well as by the Q&A at the bottom, so please send them in. We already have a few in the queue. I'll lead off by just asking, you know, this is a global consideration, the polypill, Salim. Where in the world do you think this will have the most traction, the potential for benefit at this point today?
I think given that in both rich and poor countries, in every continent of the world, conditions like hypertension and diabetes, risk factor control is poor. You know, we know that, even in our backyard in Hamilton. So in principle, this applies everywhere. Obviously, the bigger impact will be in the lower income countries. Having said that, you know, it's not just a matter of giving a pill, you need health systems to deliver it. And so in the richer countries, there are health systems that will enable us to give it. In the poorer countries, that is an added barrier that we have to get over. So I'd say it's applicable everywhere. And I would say, you know, we also had the HOPE-4 study that showed a system was important. So I'd say a polypill with a non-physician health worker, working with physicians in a team and doing community level screening. Sorry, there are cleaners who came in here. Just a minute, I'll tell them. Can you hear me now, guys? Yeah.
You bet.
So it's applicable everywhere, really. The degree to which will vary. I mean, if a polypill was available in Canada, I would use it. A lot of physicians would use it. In fact, after we published, a pharmacy in Toronto said, we can compound this for you and we can sell it for under $1 a day. Now, compare that with PCSK9. The results here of polypill plus aspirin is twice as good as the PCSK9s. Now, of course, the comparators are different.
Excellent. Aaron, do you want to take over? And you've got some questions fielded?
Question that's come in. So of course, you know, one of the things we're all excited about the polypill is the potential for improving adherence, you know, and that's the bane of medical practice is patients taking too many pills and adherence falls off. So you talked to us a lot about the whole problem during COVID related issues with compromisation with packaging and shipping. But somebody wanted to know, what was the adherence like during the good period when there wasn't these issues with the packaging and shipping or the COVID issues? How was adherence during this period?
It was pretty average compared to most trials. Okay, so it's no better, no worse. Now, Erin, in a trial, there are a bunch of reasons why people are non-adherent. First, they don't know that this thing works. Okay, so there's greater reluctance to take it. And in primary prevention, there is greater reluctance than in secondary prevention. Now, once you prove it, in clinical practice, at least you can tell the patient or the individual, you know, we've got proof it works. So that's a different scenario. The second thing is, at this age, this is a mean age of 65, a lot of people retire. We didn't think of it. And about 5 to 7% of people just moved, and they moved too far away to continue with the trial. So that was an added factor. And the non-adherence for side effects was extremely low, under 5%. It was largely like, I really don't want to take tablets. Now that may be lower if we have proof it works, people will use it. And especially if you say, if you take one capsule and you're going to have a 40% risk reduction, that, you know, a lot of people will, and they've got, and I would give it to diabetics and hypertensives. I wouldn't give it to people without any risk factors. And anyway, diabetics and hypertensives, we treat them and these drugs are indicated.
Great. Yes, I was, I was one of the co-authors of the US guidelines, the 2019 ACC AHA guidelines. And as you know, we gave aspirin a 2B recommendation, a bit of a downgrade. We had some concerns, with the bleeding risk of the 2018 trials. And Now, I know your aspirin results weren't statistically significant, but definitely trended in the same benefit as we've seen in prior aspirin trials. But, you know, if you're thinking about a polypill and giving it to the populations and trying to think about net benefit versus the net harm of bleeding, you know, what is your thought about, you know, having aspirin, you know, if we were to manufacture a polypill and make this commercially available, about, you know, including aspirin in the polypill?
You know, what I would do is, first, remember, we didn't give it to the population. We gave it to medium to high risk people in primary prevention. You know, 80% had hypertension, 37% had diabetes. So that's not your average population. But these are people who are undertreated. I actually don't subscribe to the view that you need to put everybody over 50 respective risk factors on drugs. That was a big step backwards when Walden Law suggested it. It's brilliant scientifically, but from a practical point of view, how can we put a large proportion of the people over 50 on these drugs? And I wouldn't personally. But to me, the choice is when somebody has hypertension or diabetes, it's a no-brainer to use. The second thing is, I personally, first, aspirin is a very difficult molecule, okay? If you put it into a polypill, it acetylates all the other compounds. So even though I may say give a polypill and aspirin, I would blister pack them separately. You know, I wouldn't give them, because it's a huge formulation job. We had a polypill with aspirin in our pilot studies, but they were only 3 months. So I don't know what the stability long-term is. So, you know, if now I told you, why don't we give it to a diabetic or a hypertensive, a polypill, and if they don't have contraindications to aspirin, give ultra low dose of aspirin. That's a different issue. The other thing is, I think even 75 milligrams may be too much. There is a trial from the Netherlands called the Dutch PAD trial of about 3,000 people, published in the Lancet in the mid-1990s, where they compared 35 milligrams of aspirin versus 275 milligrams. Statistically, there wasn't any difference in efficacy. If anything, it was better. Event rates were better at the lower dose, but there was a big difference in bleeding. And so the main problem in primary prevention is a concern of bleeding. So if you mitigate the bleeding by patient selection and by using ultra low doses, I think then the benefits will outweigh the risk. In North America, we tended to use higher doses. I think even 75 milligrams that we used, while that is at the low end of what's been done at trials, I think that too maybe should be lower.
Great, thanks, Salim. So many more things to answer with sub-studies of tips, and I'm going to move us along to pass the torch back to Harriette. Thank you, Salim, for joining us. Pass the torch back to Harriette to introduce our next speaker. Thank you.
Wonderful. Well, I am absolutely honored to welcome Professor Stefan Anker, who is Professor of Homeostasis and Cardiology and Metabolism at the Charité University Berlin. He is a scientist with more than 950 publications, 91,000 citations on the Heart Failure Association board, and editor-in-chief of the ESC Heart Failure Journal. He was an investigator on FIDELIO-DKD, which he will now present. Welcome, Professor Anker.
Yeah, thank you so much. Great pleasure to be here. And if anybody complains about 7 p.m., for me, it's now, I think, 1:30 a.m. So it's okay. But yeah, I have nothing else better to do than this. This is a great job that I think I really like. I like to speak about successes. I like to speak about chronic illness and making it better. And this was one of the things we tried to do in Fidelio.
In your life. We can help you focus on protecting what's important.
Okay. Okay. Well, basically, Fidelio is on the backbone of other studies that were done before. And we see that despite the successes, for instance, in renal, there's still a high residual risk in CKD progression, despite these current therapies. You see here losartan, basically you might consider a RASI therapy or hemodynamic kind of change therapy. It had an impact, but still residual risk is high. If you take the more recent studies with SGLT2 inhibitors and you change the metabolic profile of patients, still a lot to do for these patients, although the successes with SGLT2 inhibitors on cardiovascular and renal outcomes are rather big. And if you want to look at an additional factor you might want to interfere with, inflammation and fibrosis could be it. And the idea was that with mineralocorticoid receptor antagonism, particularly with finerenone, where the thought is that there is less hyperkalemia associated with this, that we may achieve additional benefits in patients with CKD. And taking a high-risk population, like also suggested by Salim, patients with type 2 diabetes and CKD were really the target. The design was very simple, randomization of finerenone versus placebo 1-to-1. There was only one issue, that patient with a GFR of less than 60 got 10 milligrams and finerenone 20 milligram was given to patients with a GFR of 60 or more. We had key endpoints here. First, the composite primary endpoint focusing on renal outcomes, kidney failure, sustained decline in GFR and renal death, and secondary outcomes, including cardiovascular events. And I would like to say there is a kind of sister study, Figaro, focusing really only on the cardiovascular outcomes. This study here is mostly in patients with very high and high risk. If you take albuminuria and GFR, the Figaro study is in somewhat lower risk. But here in Fidelio, we looked at patients that came from around the world, North and South America, about 28%, Asia 28%, in Europe 42%. That's the bulk of the 5,700 patients included from 48 countries in the study. Looking at the patients, here are some highlights of the baseline characteristics. Mean age of 65, 70% men, hemoglobin A1C of 7.7, and the blood pressure you see here, 138/76. Patients were already on RASI therapy. You can see here ACE inhibitors or ARBs essentially in all patients. Few patients were on SGLT2 inhibitors or GLP-1 receptor agonists, but altogether, if you take glucose-lowering therapies, almost all patients were on this. Here's the kidney function information for baseline, and you can see that more than half the patients had a GFR of less than 45 at baseline, and basically 88% of patients had a albuminuria above 300. Straight into the outcomes. If you take the primary endpoint, that's the kidney outcomes, there was overall an 18% and highly significant reduction. And this basically brings a number needed to treat of 29. If you basically look overall, the curves diverge after about 12 months, and that's kind of fitting with the experience. It takes time for renal endpoints to become significantly different, and at least 3 to 4 years of follow-up are needed to achieve positive results that also meet statistical assessment. Now, if you look into the components of the kidney endpoints, then I'd like to highlight that all components except for death for renal causes, which was very rare, contributed in a very similar way to the overall benefit on renal outcomes. Here some pre-specified subgroups, and you can see overall homogeneous results, maybe with the exception of an interaction for body mass index, and just for information, here you see also the SGLT2 and GLP-1 results, big overlapping confidence intervals. The subgroups of SGLT2 inhibition and GLP-1 receptor agonists were very small. Still we assessed this, but there is no significant interaction in all of this. If you look for the classical things, the degree of kidney function, blood pressure, no difference in the benefits seen in the study. Now, in terms of the cardiovascular endpoints, I would like to highlight that basically we see a significant benefit also for this. This was a positive surprise.
All right. So basically the composite endpoints for kidney function were seen for quite a variety of different endpoints. You can see here for the primary kidney composite endpoint, the secondary endpoint in a hierarchical analysis. Those two were significant, and thereafter it broke down the hierarchy, and everything else is nominal. The change in albuminuria was also significant, but anyway, this together with the secondary composite endpoint that was then using a different GFR definition, these things were nominal in the trial. Well, if you look here also into the summary of the outcomes, you can see that the cardiovascular outcomes affected mostly the death for cardiovascular reasons and the non-fatal MIs, but for instance, not stroke. So overall, we can say that there was 14% benefit for hospitalization for heart failure and cardiovascular death. There was a 20% benefit for non-fatal MI, but not for stroke, just showing you here the Kaplan-Meier curves. And then an important subgroup analysis showing no significant interaction for the patients with and without a history of cardiovascular disease overall. And if you want to know whether there is different cardiovascular diseases that made a different kind of impact, take peripheral artery disease, coronary artery disease, prior MI, then there is for each of these different approaches to looking at prior cardiovascular disease, no significant interaction for the primary outcome result. Now, if in terms of the effects on eGFR over time, interestingly, also in the first 4 months, you have a reduction in the eGFR, very similar to what you see also with SGLT2 inhibitors. But after the first 4 months, you have a long-term stabilization and less decline in kidney function over time, so that towards the end of the trial, also in absolute numbers, kidney function is better. Now, in terms of potassium, which is a important discussion point here, you can see here the changes in potassium over time. There was about a 0.3 difference over time in the mean potassium values for patients. Of course, there is a wide variety for all patients with diabetes and kidney disease for potassium values. So maybe it's more informative to look at the different kind of events related to hyperkalemia. And if you look at this, yes, there was hyperkalemia that is more frequently reported by the investigators or led also to interventions of some kind. Permanent discontinuation due to hyperkalemia 2.3 versus 0.9%. Of course, that is to some degree a problem. If you then look at 5.5 or 6.0 as the cut points for hyperkalemia, how often that happens, you can see here that about 2.5 times more frequent with finerenone. But this is about the only real side effect. Otherwise, you have event reductions. We need to keep hyperkalemia still in mind. Even new MRAs are not a complete solution of the problem, less frequent than with spironolactone, but still to some degree present. So let me conclude from this presentation and what we had published also at the AHA. We have a reduction in the progression of chronic kidney disease in patients with type 2 diabetes and CKD by about 18%. That is accompanied with a risk reduction for cardiovascular events. And also this was recently published in the New England Journal. It was a great pleasure to present and show you this data. I'm very happy to discuss it now. Thank you so much.
Wonderful. Dr. Anker, thank you so much for your presentation and congratulations on both a well-executed trial and the publication in the New England Journal of Medicine. My first question is one about sequence of initiation of this drug relative to SGLT2 inhibitors. Can you compare the treatment effect of finerenone to dapagliflozin and dapa-CKD or canagliflozin and credence, bearing in mind the differences in study design between the trials, but this might help guide us regarding this question of where finerenone fits in both international guidelines and also some of the newer trials that have demonstrated remarkable efficacy of the SGLT2 inhibitors in chronic kidney disease.
Well, yeah, thank you so much. This is an important issue, and I give you the end of my answer first. I think you should give both types of therapies in such patients. There's benefits you can get from these for different mechanisms of action and different ways they bring about their benefits. If you want me to compare the magnitude of the benefits, I would say that SGLT2 inhibitors seem so far to have a bigger magnitude of effect than these drugs. Now, there is still the Figaro study to come, and this population may be more similar to some of the other populations, so we shall see how things turn out if the degree of kidney dysfunction is lesser in such patients. But I guess this is the first kind of look comparison would be that SGLT2 inhibitors, now shown in several different trials, have a somewhat bigger effect. However, I would still think that the effects of the two classes of medications are additive. This has to be proven, I guess, in more detail at some stage, but at the moment, there is nothing that would argue against that.
Right, and my second question is related to the first question. They were less than 5% of patients in this trial on SGLT2 inhibitors. So certainly the subgroup analysis is not powered to answer this question, but would you say, based on the risk estimates of that subgroup analysis, that the effect of finerenone was slightly attenuated, or at least there was a hint of it, not statistically significant? I mean, you had long tails around the risk estimate, but is this something that's worth exploring further, that there might be an attenuated effect in patients who are on SGLT2 inhibitors?
Again, let's start from the end. Absolutely worth exploring and needs to basically looked at. That's why I also highlighted it in my presentation here, because that's what everybody is asking. But still, of course, we need to accept that some of the confidence intervals were actually the lower end was lower for the group with SGLT2 inhibition than without. And we recently learned that we need to observe confidence intervals. We have learned it in heart failure. For instance, if you want to compare the cardiovascular mortality benefits in heart failure between different SGLT2 inhibitors and would like to make them the same comparison in type 2 diabetes itself, you might get completely opposite results. And we need many thousand patients with both therapies on board to really make proper judgments of the interference here. I would not be willing to bet anything on these point estimates. I would be willing to accept that the confidence intervals are correct, but where the point estimate is, I think we shall see.
Wonderful. Erin, would you like to pose the next question?
Oh, this will just be a quick one, because I think you said at the beginning, but one of the audience members wants us just to remind us, what was the lowest GFR and the highest potassium allowed in the trial for the inclusion criteria?
5 for potassium, lowest GFR was here 30.
So I have another question, and we'll have to wrap up after it. What about type 1 diabetics? This trial didn't include them, but
this trial was for type 2 diabetics. And so this basically, I should say GFR was 25 at the lowest, not 30. But this trial was not for type 1 diabetic patients.
And somebody else had asked about other MRAs and the utility of other MRAs in this patient population. I think they had mentioned spironolactone. What your thoughts
Yes,
are?
spironolactone and eplerenone are, of course, those that are long known. My understanding is that other MRAs are in research phase. I'm not involved in these studies, so I can't tell you details, but this certainly is in a field of expansion of options.
And final question from an audience member. Tell us about who you would not initiate this therapy in.
Well, of course, somebody with current hyperkalemia or past hyperkalemia, that really is a problem patient. Under the protection of potassium binders, I might be willing to do it, but this is really not for the time being. Well, and then, of course, a CKD patient without diabetes, not really studied, and so I don't know. But of course, then when those patients have heart failure again, I would feel much more comfortable because there is a lot of experience in such patients. That's probably about it. I mean, maybe also there's one problem. If you, and this is a relevant problem for COVID times. If you don't have the ability starting this medicine to recheck the potassium in the next week or two, once or twice, then it's a problem as well. So because letting the patient start such a therapy in an uncontrolled way, I don't think that's advisable.
Right, and our audience members can check some of the exclusion criteria, which would list further patients that you don't want to include in this intervention. Thank you so much, Dr. Anker, for your time. We're sorry that you had some technical challenges, but glad you could make it back to us. We appreciate your efforts and look forward to seeing you again. Thank you.
Thank you so much. Bye-bye.
Our next speaker is Dr. Deepak Bhatt, and it is my honor to welcome him to this program. He is the Executive Director of Interventional Cardiovascular Programs at Brigham and Women's and Professor of Medicine at Harvard Medical School with over 1,600 publications, several practice-changing trials that he has led. I'm not sure if he sleeps at all, but he is here as principal investigator of the SOLIST trial, which he will present now. Welcome, Dr. Bhatt.
Oh, it's great to be here with you. Thanks so much for the invitation. I really appreciate this opportunity. Well, let me go ahead and get started. I know that we got a tight schedule and I've got about 10 minutes, I think, to do this. So I was asked to present the SOLIST trial. It was just presented as a late breaker at the American Heart Association, and the details are in the New England Journal of Medicine. These are my disclosures relevant to this talk. The SOLIST worsening heart failure trial was initially sponsored by Sanofi and then by Lexicon, and I did receive research funding from both, paid to Brigham and Women's Hospital. And through the course of this presentation, I will be discussing off-label and investigational uses of drugs. So let's start a little bit about SGLT2 inhibitors. We heard in Dr. Anker's talk just now a bit about SGLT2 inhibitors and MRAs and their interplay and so forth. Well, the data for SGLT2 inhibitors is really quite robust at this point in patients with diabetes and patients even without diabetes, with heart failure, with reduced ejection fraction, or CKD, an immense amount of data, really impressive. One question that has persisted, though, is when to start these agents. Is it safe to start an SGLT2 inhibitor during a hospitalization for acute decompensated heart failure? Well, that's what the SOLIST worsening heart failure trial was about. And in this trial, and actually this figure is going to be published later this month, it's in the ESC Heart Failure Journal. It'll be coming out. Dr. Anker and Dr. Berman and Dr. Bhatt were co-authors. At any rate, this describes exactly what SOLIST worsening heart failure was going after. Patients who had been hospitalized with decompensated heart failure. Now, of course, we wanted patients after initial stabilization off oxygen, off intravenous diuretics, off intravenous inotropes, but prior to discharge, and we got about half the patients in the trial right before discharge. The other half were randomized within 3 days after discharge, so about half and half. And the goal was really to find incremental benefit over established available generic therapies like ACE-ARB, beta blockers, and MRAs. Now, SGLT2 inhibitors have a host of different beneficial effects. I don't have the time to go through them, but I think at this point in time, it's commonly appreciated that they are more than just glucose-lowering drugs with beneficial effects on things like myocardial energetics, on progression of kidney disease, really a remarkable class of medications. What we studied was sotagliflozin, which is an SGLT2 inhibitor, but also an SGLT1 inhibitor. SGLT2 inhibition leads to glucose excretion in the urine. SGLT1 inhibition leads to enhanced glucose elimination in the digestive tract, in addition to the effects in the kidney. So a dual SGLT1/2 inhibitor. And what we found in the SOLIST trial in about 1,200 patients who were randomized to sotagliflozin or placebo was a significant reduction in the primary endpoint of total cardiovascular deaths, hospitalizations for heart failure, and urgent heart failure visits. This was reduced by about 33% or so, a hazard ratio of 0.67, a p-value of 0.0009. And in terms of numbers needed to treat, a very low NNT of 4. That is, 4 patients would need to be treated for 1 year to prevent one of these events. So very large relative and absolute risk reductions. Beyond the magnitude of effect, the benefits kicked in pretty early. That is, by 1 month, there was a significant difference in event rates. So for that physician who says, I'm going to wait to start the SGLT2 inhibitor in this heart failure patient with diabetes, maybe when I see them in a month, or 3 months or 6 months, that's fine, you can do that, but potentially then there is a chunk of avoidable events that are not prevented. In addition to doing better, we also looked at whether patients were feeling better with the Kansas City Cardiomyopathy Questionnaire, and this was evaluated at baseline in 4 months in this blinded trial. And what we found is shown here, a difference in means of about 4, which in the context of the KCCQ is pretty good. And this was a statistically significant difference. So patients were doing better and they felt better. We looked across a variety of pre-specified, also post hoc subgroups, and pretty much across the board, there was a consistency of benefit. This was true in the patients who were randomized after stabilization, but prior to hospital discharge, and in about the 50% of patients randomized after discharge in the 3 days or so afterwards. So whether you started it right before discharge or right after, similar benefit. Now there might be benefits in terms of adherence and other things to starting in the hospital, but at least in our study, either approach seemed to be fine. As well, we looked at patients based on their randomization stratification factor of EF less than 50 or greater than equal 50%, HFpEF or no HFpEF, and in both cases, a consistent benefit favoring sotagliflozin versus placebo, really the first prospective demonstration of an SGLT2 inhibitor being effective in HFpEF, or for that matter, any drug being effective in HFpEF. Not shown here, but relevant to Dr. Anker's presentation and Dr. Van Spall's question, there was also a consistent benefit in the 60% or so of patients who were on mineralocorticoid receptor antagonists at baseline. In fact, the hazard ratio was 0.6 something or the other. So, and not that one should look at p-values and subgroups, but the confidence intervals didn't cross unity, suggesting in a non-randomized fashion that perhaps SGLT2 inhibitors plus MRAs are really a good marriage. Let me now move on briefly to discuss the SCORE trial, which was presented back-to-back with the SOLIST trial and also separately published in the New England Journal of Medicine. This trial studied the same drug, different population, about 10,000 plus or so patients with diabetes and chronic kidney disease. SOLIST was diabetes plus acute decompensated heart failure. Those were inpatients. These are outpatients, but the same drugs and the same primary endpoint, total cardiovascular death, hospitalization for heart failure, and urgent heart failure visits. And once again, a significant reduction in this primary endpoint, about a 26% relative risk reduction, a hazard ratio of 0.74, a p-value of 0.0004. Here the NNT is a little bit larger, 54, in this stable outpatient population, as opposed to the SOLIST acute heart failure population, but nonetheless, a respectable NNT. That was the heart failure related endpoints. What about MACE? Well, we also looked at the total number of cardiovascular deaths, non-fatal MI or non-fatal stroke, and this too was significantly reduced, a hazard ratio of 0.77, a p-value of 0.002. And as you can see, the post hoc endpoints individually of total fatal or non-fatal MI or total fatal or non-fatal stroke were respectively having hazard ratios of 0.68 and 0.66, with confidence intervals not crossing unity, showing for the first time a significant reduction in the endpoint of stroke with an SGLT2 inhibitor. As well here, the benefit for the heart failure endpoints, but interestingly, also the MACE endpoints kicked in early in this outpatient populations, statistically significant for the heart failure endpoint by around 3 months, and statistically significant for the MACE endpoint by around 3 months. So early benefits on both counts. We also examined the effects of sotagliflozin versus placebo on hemoglobin A1C in patients with moderate and severe eGFR impairment. And in both cases, there was a significant incremental benefit of sotagliflozin versus placebo in the hemoglobin A1C. So unlike other SGLT2 inhibitors, even in that eGFR less than 30 range, severe kidney failure, there those sorts of patients were benefiting from this particular SGLT2 inhibitor, likely due to the SGLT1 effect. Now, quickly, let me just go through the pooled analysis of SOLIST and SCORED, which has been presented at AHA but not published. Here, looking at the overall patients with the endpoint of total cardiovascular death, hospitalization for heart failure and urgent heart failure visits. A significant reduction in the pooled data set is in the individual trials. That's not surprising. But what I want to point out to you is the significant reduction in events in those with HFrEF, but also in those with HFpEF. So SCORED confirming what was seen in SOLIST in a separate trial, but in patients with heart failure enrolled as outpatients, so heart failure in their history. So a drug that seems to work in both HFrEF and HFpEF. So what are the implications then of these two studies? Well, with careful patient selection and monitoring, I believe now as a class, SGLT2 inhibitors should be strongly considered in the majority of patients with type 2 diabetes, including those admitted with acute decompensated heart failure with either reduced or preserved ejection fraction, and with CKD across the full range of proteinuria. I didn't mention, but SCORED enrolled patients not just with macro, but also microalbuminuria, also normal albuminuria for that matter. Unlike with the pure SGLT2 inhibitors, it does appear that the SGLT1 inhibition from sotagliflozin provided glycemic control even at the lower ranges of eGFR. And the lower rate of MI, and particularly stroke with sotagliflozin, does suggest an additional relatively early anti-ischemic effect of SGLT1 inhibition, which really should be explored in further trials. Well, thank you very much for your attention. I hope this quick review of SOLIST and SCORED was useful to you.
Thank you so much, Deepak, and congratulations on 2 great trials executed to perfection despite the barriers you faced in funding that caused you to change your primary outcome. And how wonderful that for both trials, the original planned outcome and the revised outcomes were consistent and demonstrated a benefit of this drug in both populations.
Well, thank you very much.
I wanted to ask you your thoughts on the efficacy of this drug in HFpEF. So a minority of your patients in SOLOIST had HFpEF, a majority were in the mid-range or reduced range. And there was a benefit across groups of EF. This is in contrast to the EMPEROR reduced trial where the benefit of empagliflozin was attenuated in the higher EF category. What are your thoughts on the discrepancy between these 2 trials and their findings in HFpEF? I know one was ambulatory, one was inpatient, but beyond that, what are your thoughts?
Yeah, great question. So, and also trying to incorporate a question here from Dr. Kaiser as well. I think what we saw with respect to SOLIST and SCORED in terms of timing of initiation and in terms of HFpEF are both generalizable to SGLT2 inhibitors as a class. Now, I predict that Emperor Preserved and Deliver with empagliflozin and dapagliflozin and HFpEF respectively will be positive. We should wait and see what those trials show. Those are important trials. They need to reach their logical conclusions. But I do think what we saw in SOLIST, and in fact corroborated and scored with respect to HFpEF, will be borne out in those trials as well. Now, for the reason you just mentioned, Emperor Reduced, why did it seem like there was sort of an EF-dependent benefit? I think it gets sort of tricky because it could have to do with differences in intensity of concomitant therapy, for example. With HFrEF, there's lots of great therapies. One can debate how well they're implemented in real life, but at least in the context of the trials, someone asked what was the background therapy in SOLIST. It was excellent. We had very high rates of ACE, ARB, MRA, and beta blockers. So in terms, we even had ARNI use in there, but in terms of generically available therapies, very high in both trials. So I really think this is incremental, but for HFrEF, those are evidence-based therapies. For HFpEF, we kind of like to think MRA works, but TopCat, strictly speaking, didn't meet its primary endpoint. So it's not really clear, other than just overall probably good glycemic control and good blood pressure control, what might really work in HFpEF. So it's possible the intensity of concomitant therapies differs. It's something we'll have to explore in subsequent analyses. But I think as a general principle, what we saw in both SOLIST and SCORE, that is benefit across the full range of EF, will be borne out in other SGLT2 inhibitor trials. I'll also mention, the HFpEF discussion is interesting, but a lot of the HFpEF patients with diabetes, at least, have other indications to be on an SGLT2 inhibitor anyway. A lot of them have macroalbuminuria, a lot of them have microalbuminuria. So I think we should really start looking for reasons to start SGLT2 inhibitors in our patients with diabetes, especially if they have heart failure, either with preserved or reduced ejection fraction and or CKD.
Erin, do you have a question from the audience you'd like to pose?
Yeah, so SOLOIST enrolled patients with diabetes. We know that other SGLT2 inhibitors seem to have equal benefit for heart failure in patients with and without diabetes, but sotagliflozin is a little different because, as an SGLT1 inhibitor in addition to SGLT2 inhibitor, and so whether you feel comfortable extrapolating this to heart failure patients who don't have diabetes with this particular agent.
Great question. So this is an investigational agent at the current time, so it's not an option. I do think findings from SOLIST and SCORED are and should be actionable. And I do think that the results of at least the HFpEF part and the starting in the hospital once patients are stabilized with caution and monitoring are applicable to SGLT2 inhibitors as a class. My hope is that sotagliflozin will get approved. I have encouraged the company that sponsored the trial to go to the FDA. I think we should. I'm hoping that they do because I think the drug has a good chance of getting approved. But whether it should be used in those without diabetes, I really think would require further study. That SGLT1 inhibition does lead to additional glucose lowering. Would that be an issue in someone without diabetes? I don't think so, just like the SGLT2 inhibitors were shown to be safe, but it would need to be formally studied. We actually did want to study patients without diabetes in SOLOIST. We planned to, but ran out of funding. So we had an amendment ready to go to allow patients without diabetes, but because of COVID and financial issues with the company, that part of the trial never materialized. So I think, from DAPA heart failure, great data in those without diabetes, a labeled indication in the US for dapagliflozin, and HFrEF even in those without diabetes. Whether that should apply to sotagliflozin, I think we have to wait and see. But there's a question here from Dr. Zyroth as well about sotagliflozin. Will it be marketed, in Canada, the US? Again, it depends on what the FDA says. Then it depends on what Health Canada says. But I'm hoping we go to both and it fares well, because one real unique aspect here that isn't an SGLT2 inhibitor class effect is the benefit on hemoglobin A1C in those with really low GFR. And for cardiologists, but especially for endocrinologists and primary care physicians and nephrologists as well, that's a real potential plus for those patients who don't have a lot of options for glycemic control. And whether the SGLT1 effect on MACE, that early effect, whether that is something that's also distinct from SGLT2 inhibitors, I believe that's the case. Future studies will hopefully bear that out as well. There certainly is Mendelian randomization data that supports the SGLT1 as having an important role in cardiovascular risk, in ischemic risk.
Final question for our clinicians. who would you not start this drug on in the inpatient setting? So we're talking about diabetics, heart failure, but there were certain people that you excluded under that umbrella, and also certain people that you, on a practical basis, based on what you've seen in the trial, would probably select in the outpatient setting. So can you guide us about the management tips?
Yeah. Yeah, so those are all really important and really great questions. So with this drug, as with all the SGLT2 inhibitors, one has to be just aware of potential side effects. DKA, diabetic ketoacidosis, can occur with these drugs, SGLT2 inhibitors, including at glucose levels that are lower than one typically sees DKA. So in using them, have to be careful about that aspect. As well, it's really important to realize that the SGLT2 inhibitors can cause genital mycotic infections, both in men and women. So need to be aware of that side effect. In terms of unstable patients, really sick patients, that's not the time to start SGLT2 inhibitors. In fact, you might need to hold them in patients that are really sick and fragile and hospitalized and undergoing invasive procedures. So that's just general caution for SGLT2 inhibitors. In this trial, SOLIST, we made sure that patients were stabilized. So even that 50% of patients where therapy was initiated in the hospital, they had to be off oxygen. They had to be transitioning from intravenous to oral diuretics. They couldn't be on intravenous inotropes, so they had to be stabilized before they could get in. And we excluded patients with end-stage heart failure. We excluded patients with recent ACS or stroke or PCR CABG, though that I don't think is really an issue. And we did exclude in SOLIST those with an EGFR less than 30, though in SCORED, those patients, there were some of those as well, as I showed. So the real concern is just make sure that the patient is stabilized, that their kidney function isn't just all over the place, wildly fluctuating, that they're hemodynamically stable. If those things aren't done, this strategy could backfire. So, you know, there does need to be a prudent physician behind the initiation of the SGLT2 inhibitor in that patient who's been hospitalized for heart failure. But, you know, we did a large international trial and we had great investigators and they were able to do it safely. So I do think physicians in practice can do it as well, but they do need to be familiar with this class of drugs, including the side effects.
Well, thank you very much for joining us and for presenting your work for the umpteenth time and for sharing with us your tricks and tips on managing patients on this drug, which we hope will be commercialized in Canada and approved for use. Thank you so much for your time.
Yes, thank you again for the invitation. Really appreciate it.
My pleasure, our pleasure.
Thank you. And maybe I'll take over here now and introduce our last speaker of the evening. It's been fun so far, but we're going to have Jason Andrade from University of British Columbia, Vancouver General Hospital. Jason's an associate professor, cardiologist, electrophysiologist who's been quite active in clinical trials for AFib ablation with such technologies as cryoablation, and now to present the early AF to deal with timing of AF ablation as well as technique. Take it away, Jason.
Thank you. It's my pleasure to join you and speak with you all about the early AF trial. So the early AF trial was conceived as a trial to answer the question about the best first treatment for atrial fibrillation. So here are my disclosures. So when we think about patients with atrial fibrillation, you know, our treatment choices come down to rate versus rhythm control. For those patients who are highly symptomatic, then we have a tendency to favor rhythm control because sinus rhythm restoration can improve symptoms and other outcomes. Recently, the East AFNet4 study showed us that there may be hard cardiovascular benefits in terms of reduction in stroke and cardiovascular death. So for patients earlier in their disease course, atrial fibrillation rhythm control may be a preferable option. But when we think about what our management options are for patients with who we desire rhythm control, and it's basically down to antiarrhythmic drugs or ablation. So antiarrhythmic drugs we know have limited benefit in terms of their efficacy, and there's the potential for toxicity. And this is something that was highlighted from the AFFIRM study, where they showed that if you were in sinus rhythm, your mortality was about half as much as if you were in atrial fibrillation. However, if you needed an antiarrhythmic drug, that increased your mortality by about 50% over patients who didn't need an antiarrhythmic drug. We know in patients who have failed antiarrhythmic drugs that ablation is a more effective treatment option. So all of the randomized studies of ablation as a second-line therapy have universally shown that atrial fibrillation ablation is better. However, these studies are biased towards ablation because we're taking patients who failed a drug and using drugs as the comparator. We also know that when ablation is performed earlier in the disease, that it's more effective. So early on in the course, atrial fibrillation is a disease driven by triggers, or it's an isolated electrical problem. And so ablation performed earlier in the disease has a better outcome, which I'm showing you as the blue line on the Kaplan-Meier curve. But if we allow atrial fibrillation to fester, it'll eventually progress to persistent or more permanent atrial fibrillation, and attempts to restore sinus rhythm at that point is going to be less effective. Lastly, we know that when we perform ablation at a delay, that the outcomes are worsened. So in the top, you're looking at freedom from recurrent arrhythmia, and you see that early time to ablation in the red line is associated with better success at 2 years relative to performing ablation later in the disease course. A separate analysis in the bottom of the slide is showing you the outcomes in patients within the intermountain group, demonstrating that you're more likely to have a heart failure admission, a stroke or TIA, have recurrent AFib, or even die if your atrial fibrillation ablation was delayed from your index diagnosis. Previously, there were small studies performed looking at ablation as a first-line therapy. These were done with radio frequency. They were, between 60 and almost 300 patients. If you look at the bottom right, you see this Kaplan-Meier analysis of the freedom from symptomatic arrhythmia. And you'll notice in the green box that the studies were neutral. So ablation was not associated with, reduced recurrences of atrial fibrillation. The only one that showed benefit in preventing symptomatic AF was the RAFT-1 study, which was a non-blinded study for the outcome adjudications. So, the question was still in the air as to whether or not ablation performed earlier in the course of the disease may provide tangible benefit. So we undertook the early AF study here in Canada. It was at 18 sites from coast to coast, Victoria to Halifax. The study enrolled 303 patients with treatment-naive symptomatic atrial fibrillation, and we randomized patients to first-line cryoballoon catheter ablation or first-line antiarrhythmic drug therapy as per guidelines. One of the unique things about our study is we put a Reveal Link implantable cardiac monitor into all of our patients. So this gave us the ability to monitor their heartbeats 24/7, 7 days a week for the course of the time they were in the trial. We had standardized programming, and all of the events recorded on the loop recorders underwent blinded adjudication. So for our primary endpoint of arrhythmia recurrence, we had continuous surveillance with independent judgment of the arrhythmia events. Now, on top of that, we wanted to look beyond arrhythmia recurrence. So we looked at quality of life metrics. We used disease-specific scores and generic instruments, and these were assessed at baseline and then 6 and 12 months post-enrollment. And we also looked at healthcare utilization. And our goal was to determine if first-line cryoballoon ablation was superior to antiarrhythmic drugs as assessed by our monitors. The patients we enrolled in this study were what you would expect for early atrial fibrillation. So the average age was about 58. They were predominantly men. Common comorbidities were hypertension, sleep apnea, and obesity. From an atrial fibrillation perspective, there were a median of 1 year from their index diagnosis. They were describing 3 symptomatic episodes per month. 40% of patients had previously been cardioverted for their atrial fibrillation. And if you examine their quality of life metrics, objective scoring put them in the severely impaired category. So these were patients who were very bothered by their atrial fibrillation. For our antiarrhythmic drug group, we use standardized titration protocols. And so one of our goals with this was to provide these resources to clinicians. So if you go to the New England Journal online supplement, you can find all of our titration and monitoring protocols for the drugs. But the goal for here was to make sure that these drugs were being used consistently and that we were aggressive in our titration. So we wanted our comparator group or our antiarrhythmic drug group to have the best treatment possible to ensure that it was a reasonable comparison. And you can see in the table that's on the slide here that about 30% of patients required a change from their first antiarrhythmic drug to a second antiarrhythmic drug, and 5% ended up on a third antiarrhythmic drug. The goal was to completely suppress the atrial fibrillation on the loop recorder, and we gave the clinicians 90 days to do that. So they had 90 days to titrate the medications and get everything as well controlled as possible before we started counting outcomes. In the ablation arm, these are parameters that are important to electrophysiologists, but the procedure performed was fairly standard for contemporary practice. The procedure was a total duration of 106 minutes with 73 minutes in the left atrium, and we were using 3-minute freezes. So the ablation procedure was fairly standard overall. So our primary endpoint was any atrial tachyarrhythmia. So this is atrial fibrillation, atrial flutter, or atrial tachycardia. Detected after 90 days of enrollment out to a year. And this is anything lasting longer than 30 seconds on a continuous cardiac monitor. So here with continuous monitoring, you can see that there's an absolute reduction in arrhythmia recurrence of about 25%, which would be about a number needed to treat of 4 to prevent an arrhythmia recurrence. The hazard ratio for recurrence was reduced by about 50%. Now, as a scientist who's trying to get to the sense of sort of the truth as to which therapy is better, this is an important outcome. But our secondary outcome is more of a patient-centered outcome. So now we're looking at symptomatic arrhythmia. And similarly, we saw about a 60% reduction in symptomatic recurrence. So patients undergoing ablation, about 90% of patients were free from recurrent symptomatic arrhythmia at a year in the ablation group, but only about 74% in the antiarrhythmic drug treated group. So again, a number needed to treat to prevent a symptomatic recurrence of about 6 to 7. Having continuous monitoring devices, we were able to evaluate the burden of atrial fibrillation, or the percentage time that patients were in atrial fibrillation. A lot of atrial fibrillation was eliminated in both groups, but the mean difference was about 3.3%. That may sound like a low number, but if you apply that over a month, 3.3% of a month is 1 day of atrial fibrillation every month. That was less in the ablation group relative to the drug group. It didn't matter whether we limited our assessment to just atrial fibrillation or all atrial tachycardia, whether we looked at symptomatic or any arrhythmia, or whether we looked after multiple procedures. For every arrhythmia outcome, ablation was consistently superior to antiarrhythmic drug therapy. In terms of quality of life outcomes, we looked at EFFECT, which is a disease-specific score, so a score that's calibrated to atrial fibrillation. When we looked at generic scores like EQ-5D, so this allows us to compare between disease states, but is relatively insensitive within a disease. We saw consistent improvement in both groups. So an untreated patient who receives a treatment for their atrial fibrillation will get better. However, if you look at the treatment effect column, the magnitude of improvement was consistently larger in the group who received ablation. So for the EFFECT score, the minimal clinically important difference, so the minimal number change that means something clinically, is 5 points. And you can see that the difference between the ablation group and the antiarrhythmic drug group was about 10 points, or about double the minimal clinically important difference. If you look at the EQ-5D, it's a different scale, but same principle. You see almost twice the minimal clinically important difference favoring ablation in terms of quality of life. At the bottom, if you look at the likelihood of being asymptomatic, similar to the freedom from symptomatic recurrences, so at 12 months, you saw a significant improvement. So more patients who received ablation were asymptomatic and had an improved quality of life. In terms of healthcare utilization, there was no significant differences, recalling that this is a study of 300 patients, so we didn't have the power to see a difference. We almost saw a difference in heart failure, just any hospitalization more than 24 hours with a p-value of 0.05. However, all the other endpoints were no different between the two treatment groups. The last thing to consider when we're looking at therapies is whether those therapies are safe. And so we looked at serious adverse events related to the randomized groups, and then we looked at all safety endpoints. So if you look at the serious adverse events, there was no significant difference, 3.2% against 4%. 2 patients in each group needed a pacemaker for bradycardia. In the ablation group, 3 patients had a transient phrenic nerve injury that resolved within a day, within a week, and within a month. In the antiarrhythmic drug group, we had 3 pro-arrhythmic events. So 1 syncopal episode in a flecainide-treated patient who had a tachycardia at 216 beats per minute in the context of a myocardial infarction. We had 2 wide complex tachycardias, which you can see the loop recorder tracings of the events. The bottom one being a polymorphic ventricular arrhythmia on a sotalol-treated patient, the top one being a monomorphic wide complex tachycardia in a flecainide-treated patient. And we had 1 heart failure exacerbation in a patient treated with diltiazem and flecainide. If you broaden the category and take any safety event, which is what's shown in the table, again, there was no significant difference, with 9% of the ablation group having a safety endpoint versus 16% in the antiarrhythmic drug group. So in summary, early AF tells us that in a patient population of treatment-naive atrial fibrillation, a first-line approach using catheter ablation will have a significant benefit in terms of arrhythmia endpoints adjudicated using continuous monitoring. There was also meaningful improvements in quality of life and symptoms with more or greater magnitude of benefit in the ablation group. And there was no significant difference in adverse events between the 2 groups. And so I thank you for listening tonight to my presentation.
Thank you very much, Jason. That was an excellent presentation and a very hot topic still, atrial fibrillation ablation. I encourage people to send in their questions by the Q&A and via the Twitter handle for Aaron to handle. I'm just going to lead off, Jason, across Canada, and we have some international viewers here tonight, but across Canada, many groups struggle to manage the waiting list of patients who are referred for atrial fibrillation ablation. So what do you think early AF teaches us about the waiting list, the consequences of waiting, times for waiting, which are ideal, and how we should manage patients this way?
So I think there's a couple of elements in there. So the first thing is we know from the data that I showed you to introduce it that the longer you wait, the worse the outcomes are. We did a different randomized study, which was circa dose, where we showed that patients who had atrial fibrillation episodes of longer duration derived less benefit from ablation, whereas if you ablated them earlier in the course of their disease, they're more likely to have a good outcome from their ablation procedure in terms of preventing recurrence. So definitely, not leaving the disease to fester along the way is a beneficial approach in terms of the outcomes. Now, the flip side is, although every endpoint was better in the early AF study, there was still benefit with antiarrhythmic drug therapy. So patients did derive symptomatic improvement being treated. So, you have something that you can do to temporize. I think in a non-resource constrained environment, ablation may be your preferred first avenue, but in a resource constrained environment like we're describing, you have to be a bit more selective in terms of which of those early patients are likely to derive the best benefit and should be prioritized. And so I think that comes back to the clinician's judgment around their patients, as well as patient priorities and patient preferences. I think at the minimum, early AF at least gives us the information that allows us to have an informed conversation with our patients and their priorities and help us make a decision that's compatible with their needs.
All right, thanks, Jason. And before I hand it off to Aaron for a few questions coming in from the virtual world, just a reminder to the speakers, they can, any unanswered questions, they can knock off themselves by answering to the Q&A, which goes out to all the attendees. Aaron?
Yes, so in my understanding, you used cryoablation. Somebody asked, do you feel that RFA would have yielded the similar benefits? And then, the question was, how many ablations do people need on average? Your trial was 1 year, and we know if people followed perhaps for longer, 3 years, whether people would need redo procedures. And so I didn't know if you wanted to comment on those issues.
Sure. So the first question about RF versus cryo, that's always a bit of a debate in terms of the efficacy. I alluded to it before in the sense that we just published last year a randomized study looking at using contemporary contact force RF against cryoballoon ablation in patients who had failed antiarrhythmic drugs. We did not see a difference overall in the trial. So it seemed like the 2 technologies were comparable in terms of the outcomes that would be observed. The one thing that we did see in that trial, and that has been seen in other jurisdictions, is RF is very much operator dependent. So a good RF ablator is good, a bad RF ablator is bad. And there's a wide spread in terms of the success rates there. Whereas cryo is a little bit more reproducible. You don't tend to see the site-by-site variation in outcomes. And that was actually one of the things that led us to use cryo in the study. We thought that that allowed us a way to tackle this question from a different approach. And so, you know, probably you would expect comparable results in a good high volume center with experienced operators using RF, but I don't know that it's as generalizable out into the general population, especially in places where, you know, lower volume centers may be doing or attempting to do these procedures. What was the second question?
It was about the length. So you had a 1-year trial,
right.
and I was wondering about redo procedures and what if we followed people longer?
Sure. So definitely, you know, there is always the concern about the need for redo procedures and touch-up procedures. I sort of flashed on there the redo rate in terms of the ablation group. It was about 10%, if I recall, but you know, limited follow-up. I mean, I guess the argument or the hypothesis that we're testing is that by jumping in earlier with an ablation, we can maybe get to the mechanism for why people are having atrial fibrillation and prevent that progression. Whereas temporizing with drugs allows the disease to progress along, and then you jump in later and the horse may have already left the barn. And so hopefully, as we do this study and follow these patients out to 3 years, we'll see that the need for those repeat procedures is lessened by the fact that we intervened early. And I think that's the, you know, the main hypothesis of doing these procedures right off the bat is that we can prevent people from coming back to the emergency rooms, getting hospitalized, and needing multiple procedures to improve their outcomes.
Okay, great. Then I have another question, which interests me. I'm an echo person, I'm a non-invasive person, but this was a question about left atrial size. So the mean left atrial volume was 35 mils per meter squared. And so was there any interaction about success rates or whether predictive of unsuccessful outcomes for the patients that had larger left atrial volumes, bigger atrial size?
So we did a subgroup analysis, which is in the supplement. For left atrial size, we actually didn't see any difference. So those patients who had an abnormal left atrial dimension or left atrial volume had the same overall outcome compared to those who had normal left atrial size. The flip side of that goes back to your previous question in the sense that the low volume or centers that were in our study, the outcome was more comparable to the antiarrhythmic drug outcome. So the benefit was really in the higher volume centers, not the lower volume centers. But atrial size didn't have the influence.
And one more, we started off with the polypill and resource for countries. And so I wanted to get back to this. This is a very, high-end procedure and about cost effectiveness. And whether if this is more successful, even though there's a lot of upfront costs with the procedure, are you planning to do any cost effectiveness analysis?
Yeah, so we have a call tomorrow morning at 7 a.m. to discuss the cost effectiveness analysis. So, for us in BC, we work in partnership with Cardiac Services BC, which is our provincial agency. And so we're doing cost effectiveness analyses at a local level, and then we're looking towards some international collaborations to see how the results would apply in Europe and the US as well. So definitely, as we move from the science of the study to the implementation world, we want to see that there's value in doing these procedures earlier in terms of healthcare resource utilization as also to the patients.
All right, Jason. So any final words on AF ablation? Are we doing about the right amount? Will we be doing more in the next years based on early AF and other trials in this regard, EAST, for example?
I think that what we're seeing in the past couple of years is a maturation of the technique and the technologies. And so with Castle showing the outcomes in the heart failure population, the AF guidelines in Canada used to shy away from ablating patients with structural heart disease because we perceive the outcomes to be worse. Castle and ATAC are telling us that there's tangible benefits to targeting that group. Early AF and some of the other first-line studies may tell us that getting ahead of the disease may prevent some of those other outcomes. So you may see a shift in practice. I think that realistically in Canada, we're still going to be limited by, lab space and opportunity more than anything else. So I think it may shift our perceptions around prioritization about who should have these procedures earlier on.
All right, thank you, Jason, and thank you to all of our speakers. That draws our evening to the close. Seemed to fly by, and thank you to EOCI and the group with the iMedicus platform. Thank you to our sponsors, Bayer and Medtronic, and thank you to all the members of the planning committee, all the speakers, and all the audience members who chipped in with some excellent questions. And I'd like to thank my co-chair, Harriette and Spall, and Aaron Michos for doing our electronic monitoring of all of the questions and the social media. I think it's been a nice evening, and I'd like to thank everyone again, and hope to see you again soon. Bye-bye.
Thank you, everyone. Bye now.
Bye, thank you.